For that kind introduction. I'm always happy to speak, preferably in Egypt, but since nobody can travel these days, we're doing this virtually. So thanks to the organizers, in particular, my good friend Gamal Esmat, for inviting me to speak today. So my topic is cirrhotic cardiomyopathy, and there have been some new advances in insights and definitions over the past year. So I thought we would just go over those quickly in 15 minutes. I have no disclosures. The objectives of this are to understand the clinical significance, the pathogenesis very briefly, and future research needs. So we all know there's a number of cardiovascular abnormalities in cirrhosis and portal hypertension, of which I've listed many of these. And the one I'll discuss today, of course, is cirrhotic cardiomyopathy. This is actually a term that I coined more than 30 years ago in a journal, which unfortunately no longer exists today. If you want to read this entire paper, you can write to me, email me, and I'll send you a copy. But this is a term that therefore dates back 3 decades. And Zhenghua Ma, who was my research fellow at the time, and I wrote what I think is still the most cited review in hepatology in 1996 on this syndrome. And I must confess, I've been studying this now for 30 years, and for the first, about 10 or 12 years, I felt like this person, Shaolin priest, on getting skewered, that a lot of pain and agony for nothing. It's because many people told me the syndrome, if it exists at all, it has no clinical significance. But I think studies now over the past 20 years have clearly confirmed its clinical significance and importance. This is actually the first study done by a group of cardiologists more than 50 years ago now, which they studied a group of patients with alcoholic cirrhosis. And in fact, this is a complicated paper and we don't have a lot of time, but what it shows that despite tripling the left ventricular end diastolic pressure, i.e. giving more workload to the heart output, the cardiac output, did not increase significantly. So this is a sign of heart failure. And these authors did not know anything about hepatology. They just said, oh, must be some evidence of some kind of alcoholic cardiotoxicity. But they were actually probably describing cirrhotic cardiomyopathy, but did not know it at the time. Subsequent studies since then this is a study from Toronto showing that in 2 groups of cirrhosis before and those with ascites, their cardiac response to exercise is grossly abnormal. The top part of this cartoon shows a normal echocardiogram with a large early ventricular filling, the so-called E wave, and then the late atrial filling of the ventricle in diastole. So this ratio of the EA, you can see the E wave is much bigger than the A wave, but in the bottom part, you'll see that the E wave has been decreased and the A wave increases. So this is a marker of impaired diastolic function or filling. And electrocardiographic QT prolongation has been well described now by many different groups in cirrhosis. If you look at various markers like BNP, ANP, proBNP, and troponin, these are markers of cardiac distress, and they are all increased in patients with cirrhosis. So in 2005, at the World Congress of Gastroenterology, I organized a working group to come up with diagnostic criteria. And this is what we came up with at that time. However, I have to say, please ignore this slide. I shouldn't have even shown it, because we have now, we realize that these criteria are probably not accurate in many ways, and certainly not validated. And unfortunately, most of the studies over the past 15 years have used these criteria, and we've now suggested new criteria. So we formed a cirrhotic cardiomyopathy interest group, heavily Mayo-centered. First two people are cardiologists from the Mayo. Kim Watt and I organized this conference. There's John Findlay, who's a ICU anesthetist at the Mayo, and other individuals you'll see. And we came up with, one weekend we got together at the Mayo and came up with new criteria. And these are published, and the first co-authors are Izzy and Lisa Van Wagner, published in Hepatology this year with the new suggested definition criteria for cirrhotic cardiomyopathy. And it takes into account that the nomenclature for heart failure has changed. So this old term of systolic and diastolic heart failure is no longer used by cardiologists. What we have are heart failure, you'll see on bottom, with reduced ejection fraction. So the old systolic failure, and heart failure with preserved ejection fraction. So since these are so many words, cardiologists refer to this as HFrEF and HFpEF. So these correlate generally with the previous diastolic dysfunction, diastolic heart failure, systolic dysfunction, systolic heart failure. So the terminologies have changed a bit. And these are the definition criteria. So these, the main diagnostic criteria that we had adopted was actually put in place a few years ago by the cardiologists themselves. The American and European cardiology diastology committees came up with this guideline. And this is basically, we're using very similar criteria to diagnose cirrhotic cardiomyopathy now. And what's the significance? Well, here's an interesting review from Bernardi and a group of prominent European co-authors, in which they show that cardiac function in terms of heart rate, stroke volume, and most of all this solid line cardiac output seems to be related or correlated with worsening kidney function. And in fact, this is a nice review paper written by Florence Wong a few years ago, showing the crucial role of decreased cardiac function in contributing to decreased effective circulating volume, which is one of the main pathogenic mechanisms that drive hepatorenal syndrome, or AKI, in cirrhosis. Why is heart failure so uncommon? Well, there's a number of mechanisms. I think the vasodilatation treats the patient automatically, and we've also shown major compensatory decreases in inhibitory cardiac systems. So I will do this very quickly. The cardiovascular events and liver transplantation. This is some data from Lisa Van Wagner showing that, and many others have shown similar thing, that cardiovascular disease or dysfunction is a third leading cause of death after liver transplant. And there is significant numbers or rates of diastolic and systolic dysfunction after heart failure or after transplant. The diastolic dysfunction appears to be much more common. There's a huge range here because studies have different ways of defining this, but you can see that in general, diastolic dysfunction tends to be more common post-transplant than systolic dysfunction. Dobutamine stress echo does not predict who will develop either one of these. It can be diagnosed by echo with newer echoes, such as tissue Doppler imaging or speckle tracing or speckle tracking or MRI scanning. But these sophisticated methods are not available everywhere. How does cirrhotic cardiomyopathy affect post-liver transplant outcomes? These are cartoons showing the different types of cardiac events after transplant. And Lisa and her group in Chicago have come up with what they call the CAR-OLT score. And you can see the website down below here, which is a means of predicting. You get certain points for different features, and you can predict the cardiovascular risk events after liver transplant. And we published about 3 years ago our suggested cardiac assessment algorithm in the transplant patient, or the patient being considered for liver transplant. So I will just spend just a few minutes in the rest of my talk on what I've been doing for the past 31 years, and that's translational lab research in mechanisms underlying cirrhotic cardiomyopathy. We use the bile duct ligated rat as a model because it has all these features which mimic human cirrhosis. This somewhat hard to read and complicated cartoon shows all the different features in the cardiac myocyte that lead to cell contraction, calcium fluxes inside the cell, and thus cell contraction. And rather than go into all the data, which we don't have time to show, this is basically a summary of my career work over the past 3 decades in looking at different mechanisms. And in particular, the sham control BDL is just showing that these papillary muscles behave differently or blunted. A lot of our work was initially focused on the cellular plasma membrane, and you'll remember beta adrenergic receptors or inhibitory receptors are protein moieties stuck in this lipid bilayer. And if the lipid composition of the bilayer changes, which we know happens in cirrhosis, these protein moieties can't function properly. So the receptor function is abnormal. And this summarizes about the first 8 years of work from my lab showing these different plasma membrane characteristics in cirrhosis. And eventually this leads to decreased calcium fluxes inside the cell. And there are roles of these proteins or collagen structures such as titin and collagen and myosin heavy chain, which we've found to be abnormal. This is in the past 6 or 7 years. So this shows that the types of collagen isoforms in cirrhotic rat heart are radically different from controls. The collagen becomes stiffer, less compliant. So in conclusion, cirrhotic cardiomyopathy is common in advanced cirrhosis. It is not due to alcohol. It manifests with stress, and it affects outcomes during stress, such as the surgical stress, bleeding, infections, vasoactive drug therapy, and most of all, liver transplantation. And a common theme in many of the pathogenic mechanisms appears to be the inflammatory phenotype of cirrhosis. The appropriate management, unfortunately, remains unclear. So what we need to do for future is better identify those at high risk of cardiovascular events or complications post-liver transplant, agree on standard cardiovascular events in the classification systems, revise the CCM criteria, which we have done recently, and now we hope these will be validated by further research, optimize which cardiac imaging methods. MRI actually appears to be best, but it's expensive and not routinely available everywhere. Further research on cellular molecular pathogenic mechanisms is needed. And we need much more research on how to manage and treat cirrhotic cardiomyopathy. So thanks for your attention. I think we can take questions in the panel discussion afterwards. So this is just a little quote to my colleagues who were criticizing me 25 years ago, saying my study was useless. So here you go. Thank you. Shukran.
Thank you very much, Sam, and shukran for you. We'll start our discussion. Do we have Professor Sharif Migawer with us? Okay.
Yes, I'm here.
Dr. Sharif, we have a question. Pancreatic neuroendocrine tumor is uncommon nowadays. What's your recommendation for such patients? Because it's now we can see it a lot. So what's your recommendation for such patient?
As I told you, 20% of tumors, of neuroendocrine tumors, could originate from the pancreas. Anywhere where we can find enterochromaffin test, they can originate. Yes, in the gut, they are 50 to 70%, but still we have 20% originating from the pancreas. As I told you, the problem with neuroendocrine tumors is that they are usually diagnosed lately in the course of their illness. So the best thing is to have a high index of suspecting such tumors. And of course, we no way except by doing our screening test, asking the patient about family history, asking about symptoms which may be related to endocrine tumors such as carcinoid syndrome and so on. And as I told you, sometimes in early tumors, these are incidentally detected. So we have to respect any incidentally detected tumor and to investigate thoroughly in order to try to diagnose this tumor before metastasizing. Or otherwise, we will have the poor prognosis of such tumors.
Thank you, Professor Sharif Migawer. The second question for Professor Fatma Ali-Din. It is the $1 million question. What are the prophylaxis for COVID?
Prophylaxis for COVID? You have to protect yourself. Till now, there is no prophylaxis of COVID.
Yes, but
measures to protect ourselves. Yes.
So we don't have
immunity,
any. No, we don't have
social
any drugs.
distancing.
We don't have any drugs for that. This is what they want to listen from you.
No, there are till now there are no evidence-based drugs. No.
Okay.
For
Thank you.
chemoprophylaxis.
I was willing to give you the $1 million, but unfortunately, we don't have an answer for that. The question for Professor Muhammad Magdi: when you shift to surgery after using proton pump inhibitor, is there any criteria or only the symptom of the patient to shift from proton pump inhibitor to surgery?
There's no specific criteria, but we said that we should have an adequate dose of PPI firstly and see the improvement of the symptom in the patient. If the patient give no improvement or no, I am talking here about the surgery after bariatric surgery, not in cases of GERD. If I talk when I shift to surgery in patient with GERD only, I should do that when there is no compliance with the treatment, but the patient should have a good response to medical treatment. If he don't have response to medical treatment, he will not benefit from the surgery. But if we are talking about when shift to surgery after bariatric surgery or GERD complicated by bariatric surgery, so we should give an adequate doses of PPI. If the symptoms not improved within 3 to 6 months, or the patient can comply with the treatment, or we have some complication for the treatment, we should shift to surgery.
Thank you very much.
Thank you, Dr. Muhammad. For Professor Samli, the question was, shall we do each patient, for our patients, cirrhotic patient, echo as a routine? Shall we do
Yes.
that?
Yes, I think that would be useful. Perhaps not the group of mild cirrhosis, but certainly any patient with advanced cirrhosis or decompensated cirrhosis, and any patient that may be considered potentially as a transplant candidate. I think at least a 2D echo and preferably a TDI, tissue Doppler, or speckle tracking echo would be a very useful thing to look for preliminary evidence of cirrhotic cardiomyopathy. And if I could just make comment, I forgot to give a shout out to my former research fellow. He spent a year with me in my lab about 12 years ago, very smart young Egyptian fellow named Tamer Fouad. I don't know if you're listening or tuning into this conference, Tamer, but I haven't heard from you for several years. I hope you're doing well.
Okay, thank you very much. And this is the end of our session. I wish to thank Professor Sharif Migawar, Professor Fatma Ali Din, Professor Muhammad Magdi, and of course Professor Sam Lee for very elegant presentations. And also my thanks to Dr. Asim Sharif, Dr. Hala Ibrahim, and Dr. Muhammad Tahir, and thank you very much. And follow us tomorrow. We have very, very excellent lectures tomorrow, so please keep with us on the USHID website. Thank you very much.